Good morning, guys. I am Dr. Arun Priya. I'll be dealing a few chapters of pediatrics for you, and this session will be on pediatric gastroenterology. And the scheme of presentation today is starting from your lips, mouth, and then we'll go ahead of esophagus, stomach, and intestines, and so on, right? And last session of this will be dealing with your hepatobiliary system also, okay? And we'll start, guys. And starting with the cleft lip and cleft palate, right? So why this cleft lip occurs is due to the non-fusion of your median nasal process and your maxillary process. You know, there will be a median and lateral nasal process and then your maxillary process. This is median nasal process and this is your lateral nasal process, and here will be your maxillary process, right? So when this does not fuse with your nasal process, then you get a cleft lip, right? And what is cleft palate? It is due to the non-fusion of your palatal shells. So there will be two palatine shells. So when this does not fuse, usually it should fuse, right? And if it does not fuse, then you get a cleft palate. And coming to a cleft lip, usually it is can be both unilateral or bilateral, but it is, if it is unilateral, which side it's going to be, that is your question, right? So where it is going to be, it's your left side. How are you going to remember? It is cleft, so left, okay, cleft, and it is left, right? So unilateral, if it is unilateral, left side is your most common presentation. And treatment wise, you have to remember two things, right? At what age you are going to repair cleft lip and what age you are going to repair cleft palate. Only two answers you have to remember, 3 months and your 1 year. So how are you going to remember this? So lip is your 3-letter word, right? LIP. So it is almost 3 months, and then remaining is your palate, right? So palate is at your 1 year. So you are going to repair your cleft lip at 3 months of age, and you are going to repair cleft palate at 1 year of age, right? Okay, what is the complication behind it? Why should it be repaired? So if it is there, that is an increased chance of getting recurrent otitis media, and due to that there is a subsequent hearing loss. So because of these two sequelae, we need to repair this cleft lip and cleft palate, right? And coming to the syndromes associated, you need to remember these 3 syndromes in particular, right? Peary-Robin, Stickler's, and your Vanderwood syndrome. Among these 3, Vanderwood is very easy, right? What is that? Is usually cleft lip and cleft palate inheritance will be having your multifactorial inheritance, okay? So many factors contribute to it. But when this cleft lip or cleft palate is inherited in an autosomal dominant fashion, okay? If it is inherited in an autosomal dominant fashion, we call it as an Vanderwood syndrome. And what is this Peary-Robin? Peary-Robin is actually a sequence, right? The characteristic facies will have a micrognathia and a retrognathia. That is, your jaw is small as well as it is retracted back. So there is an obvious micrognathia and your retrognathia. Along with that, the child will have cleft palate, high arched palate, and a normal sized tongue, but a foreshortened floor. That is a small floor of the tongue which cannot accommodate a normal sized tongue. Okay. So what is a stickler? Stickler is nothing but an extension of your Peary-Robin, right? So when this Peary-Robin syndrome, along with Peary-Robin, if there are so many other anomalies like your eye and hearing, like ear anomalies or hearing defects, along with your eye anomalies like cataract or glaucoma, retinal detachment, and along with that few muscular problems also like hypotonia or hypermobility. All these things are present, then it is called as Stickler syndrome. So Stickler is again autosomal dominantly inherited. Along with Peary-Robin features, we also have hypotonia, hypermobility, all these connected with your muscular system. And coming to ear and eye, there can be myopia, glaucoma, cataract, and RD, all these in eye, and your ear anomalies, right? Hearing loss. So Stickler is an extension of your Peary-Robin, right? And as I told you, Vanderwood is an autosomal dominant pattern, okay? This is specific about your Vanderwood syndrome. So that completes your cleft lip, cleft palate discussion. Now coming on to your esophagus. So what is more common disorder of esophagus? It's obviously your reflux, right? So it is GERD, gastroesophageal reflux disease. What is that actually? it is only the reflux of your contents, gastric contents into your esophagus, right? That is GERD. Now, can GERD occur in all? There can be some additional risk factors who are more prone to get your GERD. So, what are they? Obviously, your obesity, right? So, obesity, your hiatus hernia, any repair defects of esophageal atresia, and your neurologically impaired children and your preterm babies. All these, they constitute characteristic risk factors. They are more prone to get this GERD. Now, coming to the clinical features. Why are we discussing clinical features is, you will be asked like a scenario, right? So, GERD, though it is an esophageal disorder, the symptoms can be including a respiratory also. So, respiratory symptoms also predominate in your GERD. The child can even present with the recurrent wheezing. We will be looking on to a respiratory cause itself, but sometimes this GERD can present as a wheezing episodes recurrently, right? So, you need to remember GERD clinical features include your irritability, right? Heartburn, right? Heartburn, irritability, which the child will say it as a chest pain. I have the pain over my sternum, my chest, right? That would be the words from the child. And along with that, if it is severe, it can even go for erosion and lead to hematemesis and your wheezing and stridor. So, now what are we going to do for this GERD? We are going to do a 24 hours esophageal pH monitoring. This will be your invasive technique, but it is very reliable, right? So, 24 hours esophageal pH monitoring and your upper GI endoscopy to identify the severity, if there are any erosions or ulcers that has been created or any other precipitating illness that can be ruled out using your upper GI endoscopy. And how we are going to manage is mainly your lifestyle changes. As I told you, obesity is one of the biggest risk factor. So, you have to concentrate on your diet and lifestyle modifications, and your supportives include H2 receptor antagonist, proton pump inhibitors and your antacids. And some cases where there is severity, like I told you, in hematemesis, if the hematemesis is a picture of your GERD, then obviously that kind of GERD may need even surgical correction like surgical fundoplications. And one syndrome associated with GERD you have to remember is